Hello, my name is Dr. Nikhil Gopalkrishnan, and I'm here with my colleague, Dr. Josie Kishi. We are from the Molecular Systems Lab at the Wyss Institute. And we are very excited today to present our work in scaling up COVID-19 testing. This is the problem that most decision makers around are faced right now. There's a public health risk of reopening, but at the same time, there's a social and economic benefit of reopening, and everybody is trying to balance these two things. And one way you want to balance these two things is to be informed. And the key thing that informs us about public health risk is testing. More testing more people will tell us where we are on this y-axis. Currently, we are not testing enough. There are some estimates that say that to fully reopen the economy, we need to test everybody every couple of weeks. That comes out to about 20 million tests every day. Our current rate of testing is nowhere close to where we need to be if we want to completely reopen the economy. However, there are barriers to mass testing. Key among them is scarcity. Especially early on, we did not have enough swabs. We did not have enough testing kits. We had problems with personal protective equipment. We had a shortage of medical health professionals to administer the test. And just because this scarcity has temporarily gone away doesn't mean that it will not come back. Especially when we scale up to millions and millions of tests, we might not have everything that we need. And then there's the other aspect of cost. Currently, Medicare reimbursement cost for a COVID-19 RT-qPCR test is between $35 to $100 per test. The cost is manageable if you're only testing maybe 500,000 people a day, but if you start testing millions and millions of people a day, the cost becomes significant very quickly. Currently, insurers are paying that cost, but ultimately, this is going to get passed on to consumers and to taxpayers. Then, of course, there are throughput bottlenecks. The key among them are sample preparation and the qPCR reaction setup. Both of these things require manual labor and they take significant amount of time, and the sample to test result has been a significant barrier to increase mass testing. However, we can do much better. We don't need to run many tests to be able to return results for everybody. And that is because if you look at the trend of how tests are proceeding, most tests are actually negative. If you look at the fraction of tests that are positive, it ranges from between 5% to about 10%, which means most people who are being tested for COVID-19 will come back negative. And if there was a smart way to eliminate these people without requiring that we individually test everyone, we could save a lot of time, cost, effort, and scale up testing. Something like this was recently done in Wuhan, which was the epicenter of the COVID-19. And Wuhan basically tested nearly 10 million people in 19 days. And they found just 300 coronavirus infections. So you can imagine that they had a massive over-testing, right? Where they were testing individuals who were mostly negative. They did save a certain amount of tests by using something called Dorfman pooling. This is a very old idea, dates all the way back to 1940s. And the idea is you can combine multiple specimens into one test tube. In particular for RT-qPCR tests, they combined 5 samples into one tube. And if the test was negative, they concluded that all the specimens in there were negative. If the test was positive, they went back and individually tested each specimen. This provides a 5x saving in testing. However, with such a low prevalence rate, you can imagine that you could do much better. For instance, you could do a multi-stage pooling and get even bigger savings. This is how something like this would work. You pool people, and if the pool test is negative, then you're done. Everybody is declared negative. If the pool test is positive, Then you split the population into subpools and then test within those subpools. Of course, the problem with this is it is not easily automatable. It gets very complicated very quickly. And the problem is you have to make decisions based on previous results. So what your current pooled test is telling you determines what you do in the next round. And these kind of flowcharts are not easily automatable. Instead, we are working with something called single round combinatorial pooling, in particularly a version called Tapestry. This is in collaboration with Professor Manoj Gopalkrishnan at IIT Bombay. So what we have here is a combinatorial way of pooling samples such that you get results back in a single round. Each sample goes into multiple pools. In particular, here you can see on the top row, you have N patients, and then a check mark means that you include that patient's sample in that particular test, and a cross indicates that you do not include their sample. By a smart combinatorial algorithm, the results of the pooled tests can be deconvoluted to give us results for the individual specimen. Now, of course, when you pool things together in a test, there's always the fear that you lose sensitivity. You could have false negatives. But with COVID-19 and the RT-qPCR tests, we believe that this problem might not be as bad. If you look at research that has come out, it indicates that especially early on, after onset of symptom, you find a viral copy of at least 1,000 or more per swab, which indicates that you could dilute these samples, and pool sizes of up to 30 should be tolerable, and we do not expect a lot of false negatives in this case. Here are a couple of examples of Tapestry matrices. On the left, you see a matrix for combining 40 patient samples into 16 qPCR tests. The green box indicates that a patient sample is included in a pool test. And of course, a white box means that it's not included. In this particular case, every patient's sample goes into 3 distinct pools. There's a companion app, Biome, that's available that will guide you through this pipetting process that allows you to set up such a qPCR reaction. However, the big scale up, the big savings with this kind of technique comes up when you go to a lot of tests with low prevalence rates. For instance, if you have over 1,000 samples and you have a prevalence rate of about 1% or 0.2%, you end up saving between 800 and 1,000 tests. However, there's a problem when you try to scale up, and that's a throughput problem. There's a significant pipetting burden associated with doing this combinatorial pooling. We estimate that if you have 1,000 samples, it might take you over 20 man-hours of pipetting to do this combinatorial process. Of course, this is not realistic, and hence that brings us to how do we automate this process using robots? My colleague, Josie Kishi, will now talk about our efforts in automating Tapestry by using pipetting robots.
Thank you, Nikhil. So to automate this whole process, we use a combination of software and hardware techniques. So we take our Tapestry pooling matrix, and using some custom software, we can convert it to a set of pipetting instructions for a liquid handler robot to follow. And we can pool these together for any type of diagnostic assay output. Once we have our assay results, we then use deconvolution software to algorithmically decode which samples are positive. And in the case of quantitative assays like qPCR, we can also predict the original viral loads of those samples. So to test the whole process, we did a proof of principle experiment with 1,140 mock samples pooled into 90 tests. So on the left here, we see our 3 384 well input plates. We spiked 12 of them with positive control SARS-CoV-2 plasmid, ranging from 500 to 32,000 copies per microliter. And we follow the pooling matrix to pool them into 90 reactions, shown here in blue. So each mock sample was pipetted into 3 separate qPCR reactions, 125 nanoliters of each, so that each qPCR reaction ends up with a total of 38 pooled samples. And to achieve these 3,400 pipetting steps, we use an acoustic liquid handler called the Echo 525, which can do this process in less than 20 minutes. So we'll watch a simulation of how this pipetting process works from the Echo software. So what we're going to see on the top left here is a 384 well input plate. So there's 3 of those that we hand the machine sequentially. And on the bottom left, we see our 96 well output plate. On the bottom right, we can see a simulation of how those plates move with respect to each other through the process. So here we're pipetting that first sample plate into those 90 reactions. Then we swap in the second sample plate. So this process is sped up here, but the whole process took about 18 minutes. And then this is the final sample plate. So you can see is every input well was pipetted 3 separate times into 3 of the 90 wells here, so that each of these wells ends up with a total of 38 pooled samples. So we also include several control reactions for quantification. We included 2 negative controls here, so no sample positive, and then 3 benchmark samples at known concentrations. So these are what the qPCR assay results look like. So purple indicates a reaction well that amplified sometime during the 45 cycles, and gray indicates no amplification during the qPCR. And using this data, our deconvolution algorithm can predict which of the original input samples were positive and negative. So our first iteration of that software identified 11 of the 12 true positives, 1,125 of the 1,128 true negatives, and we have 3 false positives indicated in blue and 1 false negative here indicated with the red outline. But actually, after further optimization of that deconvolution algorithm, we were able to identify no false positives, so all true negatives, and 11 of the 12 of those true positives. And actually, we believe that a technical error caused this single false negative because the sample did not amplify in any of the 3 wells it should have been pooled into. So we're continuing our experimental optimization to make that protocol even more robust. And because qPCR is a quantitative assay, more than just getting binary yes/no results, we can actually estimate those original viral loads. And we see a very good correlation between our expected CT values based on our benchmark qPCR reactions and the decoded CT values by the algorithm. So of course, pooling reactions together like this enables significant savings, especially when it comes to cost and time. So in this case, we compressed more than 1,000 sample tests into just 90 reactions, which saves a huge amount on reagent costs, especially our qPCR kits, which can be very expensive. And by using the Echo, we can also potentially reduce those reaction volumes to even further save on costs. This also saves a huge amount on technician time. So like Nikhil said, it could take more than 20 hours for a single person to do these 3,400 pipetting operations. But using the Echo, we can achieve this in less than 20 minutes. And finally, by automating the system, we can get very high precision pipetting. And the nice feature of using an acoustic liquid handler is we don't have to pay for consumables like tips. So using this type of method, we envision this for especially population level tracking of pathogens. We believe a single technician could potentially test thousands of patient samples for tens of different types of pathogens in a single day. And because we see the best savings with relatively low prevalence rates, so typically 1% or lower, we imagine this would be very good for things like tracking emerging strains, tracking ongoing pandemics, implementing at large employers, et cetera. And we're on the lookout for collaborators. So, please reach out to us if you're interested, and we're happy to share all of our software that we wrote for this project. So with that, I'd like to thank also our colleagues Tom Strauss, Peng Yan, and our whole COVID-19 team, as well as our funding sources. Thank you.